And welcome. Before we start the lecture today, I think it would be amiss of me not to send our thoughts and prayers to those who are caught up in the conflict in, well, the Russian invasion of Ukraine. Just a little comment. And for those of you who've not joined our Zoom lectures before, my name is Carmen Thomas and I'm the President of the Royal Institution of South Wales. If you would like to learn more about the work that we do with the institution, please do go onto our website. I need to move that there. Okay. So today's lecture will be given by Professor Graham Watt and is entitled A General Practitioner for the World, and is the third of the February lunchtime lectures on the life, work and legacy of Dr. Julian Tudor Hart. Graham graduated from the University of Aberdeen in 1976 and worked in hospital posts in Shetland, Leicester, Aberdeen and Nottingham. Graham's focus in combining training in epidemiology with general practice resulted in a move to South Wales to work with Dr. Julian Hart at Glencorrig, where they carried out a challenging series of community studies on the effect of dietary salt intake on blood pressure. Graham's long-term research interest in health and disease in families began at Glencorrig, with further work with the Ladywell blood pressure study in Edinburgh and the Midspan family study in the west of Scotland. He worked with the Scottish Chief Scientist's Office, establishing the WHO Monica Project Centre in Glasgow. Between 1994 and 2016, Graham was the Norrie Miller Professor of General Practice at Glasgow University. His interest in equalities in health and healthcare and in supporting the next generation of academic general practitioners and primary care researchers led to his involvement in the Deep End project. Graham coordinated the project from 2019 to 2016, which focused on the 100 most deprived general practice populations in Scotland. Although now retired, Graham remains an active member of its steering group. So without further ado, please welcome Professor Graham Watt.
Thank you very much. Now, I'm just screen sharing. No, can everybody see that?
Yep.
That's good. Okay, well, thank you very much for the invitation and the opportunity to put on record my recollections of working with Julian. It's a pleasure also to follow the excellent talks by Brian Gibbons and Jonathan Richards and Gareth Jones in the last few weeks. Well worth watching on the institution's YouTube channel. Now, of course, as many of you know, Julian didn't achieve what he achieved by himself. There was two of them, one of whom is in present company. Julian was many things, a scientist, a writer, a philosopher, an artist, a social advocate, a community activist. Many people do some of these things, but very few while also looking after the medical needs of 2,000 people. And it was a combination of these activities which gave Julian his authority and influence as Dr. Hart, the local GP, Dr. Julian Tudor Hart, the world famous general practitioner. And as part of this series of talks, I'm going to cover where his energy, talents and values came from, his career journey that took him to Glencorrig, the work he did there, and his wider influence outside Wales. The adage of acting locally, thinking globally couldn't be more apt. The name Tudor Hart has an Elizabethan ring to it, but its roots are in North America. The Tudors and the Harts were closely related business families, including Ephraim Hart, originally Hertz, a Bavarian Jew, New York merchant and politician, and Frederick Tudor, the Boston Ice King, who made his fortune exporting ice before refrigeration from Massachusetts to Cuba and India. The combined surname arose when Julian's great-grandmother, a Tudor, divorcing his great-grandfather, a Hart, wanted to keep both names. Julian's Canadian grandfather, Percival Tudor Hart, was sent to study medicine in Paris, which he hated, so he left to become a painter and got cut off from parental support, becoming a starving artist, a fellow student with Henri Matisse, a neighbor of Toulouse-Lautrec. His career picked up, teaching painting in Paris until the Great War, then London, then back to Canada. He became a world expert on picture restoration. In Paris, his first wife, Eleonora Klekowski, called Nellie, came from minor Polish aristocracy. She gave birth to Julian's father, Alexander, on the right, in Florence, but she died young from tuberculosis. It rings to the plot of La Bohème. While Julian's paternal grandparents were Canadian and Polish, his maternal grandparents were Scottish. His father, Alexander, having married Alison Macbeth, daughter of Norman Macbeth, born in Glasgow, an apprentice engineer in a Clyde shipbuilding firm, who married Annie McNichol from Helensburgh. The couple moved to Bolton in Lancashire, where he worked as an engineer for 30 years and where they brought up a family of 9 children. The eldest was Anne Macbeth, one of the Glasgow girls, an associate of Jessie Newbury and Charles Rennie Mackintosh at the Glasgow School of Art, where she was head of needlecraft and embroidery, but also a suffragette, designing a banner for a famous Edinburgh procession, for which she was imprisoned, put in solitary, and force-fed in 1912. As a teenager, Julian spent summer holidays with his aunt at her retirement home in the Lake District. In 1926, Anne's sister Alison married Alexander Tudor Hart. They were both left-wing doctors, but split up when Julian was 3. After the divorce, his father went to fight in the Spanish Civil War, having married Edith Chusitsky in Vienna, shown here, enabling her to live in the UK as Edith Tudor Hart. She was a photographer, pictures of South Wales, shown on the right, but also a KGB agent and the spy master for the Cambridge Four, Maclean, Philby, Blunt, and Burgess. As he said in the recent documentary, Tracking Edith, Julian had little contact with Edith Tudor Hart. He was brought up in Woburn Square in London by his mother Alison, a single parent who became an endocrinologist. It's a complicated background. Complicated background. There was medicine, engineering, art, and politics on both sides of the family. And based on his grandparents where he lived, Julian could have played rugby for Scotland, England, Wales, Italy, Poland, France, or Canada. Of course, he was never called up. Julian went to a progressive school, Darkington Hall in Devon, before being sent to stay with his grandparents in Canada during World War II. And on his return, he studied medicine at Cambridge and then St. George's in London, graduating in 1952. After 5 years in general practice in West London, where a visiting Paul Robeson was a patient, and the end of his first marriage, Julian moved to South Wales, where he spent the remaining 60 years of his life. Initially, at the suggestion of his friend Richard Dole, to obtain research experience at the MRC Epidemiology Research Unit led by Archie Cochrane. There he learnt a democratic type of research, employing streetwise local people to generate high response rates. The last person as important and often different from the first. But Julian was first, gosh, I'm jumping, but I can find the slides. Julian was frustrated as a researcher, seeing many people with clinical problems, which as a researcher he could observe but not treat. So he left. And in later life recalled his decision in a phrase from J.P. Hartley's novel, The Go-Between, exchanging a life of facts for the facts of life. In moving to Glencorrig, a mining village at the head of the Avon Valley, isolated with only one road in and out, the back of beyond as many would have seen it, he was finally, age 35, on track for his life's work. He'd always wanted to be a general practitioner in a coal mining community, partly following his father's example at Llanelli, partly due to the romance of mining practice as described in A.J. Cronin's novel The Citadel, but mainly because with his privileged, somewhat exclusive background, it was a type of community to which he wanted to belong and be included. As Gerald Davies, one of his patients, said in the BBC documentary, which you saw last week, The Good Doctor, Julian wasn't aloof like other doctors, the headmaster and the colliery manager. He lived in the village and shared the common experience, his children going to local schools. And although mainly an industrial village in a rural setting, there were several farming families on his practice list. And here on the right, you can see, crossing the footprints, Julian returning from a home visit to a hillside farm. Glencorrig was isolated enough for him to pursue without interference his vision for general practice, as he described later in a careers pamphlet for medical students published in The Lancet. No one is a stranger. They are not only patients, but fellow citizens. From many direct and indirect contacts in schools, shops, and gossip, I've come to understand how ignorant I would be if I knew them only as a doctor seeing them when they were ill. With great effort, any doctor can get to know all his patients, even in a city with high turnover. Only then can he think of a responsibility not only to the patient sitting in the surgery, but to the whole population for whose care he is paid and for whose health he is responsible. He can then see his role as the ultimate custodian of the public health on a defined section of a world front against misery and disease. He wrote, "We need more liberty, more equality, but above all more fraternity. The doctor living and working within a community, sharing as much as he can of the common experience, and being better able than any other to discard privilege and stand on two firm legs of earned respect." I think this was in many ways Julian's big idea. But at the beginning, the future was a long way off. The work was hard with huge surgeries, long visiting lists, many out-of-hours calls. Computers and mobile phones were still in the future. Being on call meant being answerable to an answering machine. Local doctors didn't all welcome this new doctor with his strange ideas. Initially, he was on his own and lonely, but in 1961, he married Mary Thomas, whom he had met at the MRC unit, lost touch with, but found her again, famously trawling through the South Wales telephone directory, looking for a farming family called Thomas. Without doubt, marrying Mary was the best decision Julian ever made. In the 1950s, there had been a famous study of general practice in poor areas by an Australian called Collins, who observed that the conditions in which many general practitioners had to work were often bad enough to turn a good doctor into a bad doctor in a short period of time. There was a lot of work to do, beginning with putting the records into shape, emptying the old Lloyd George envelopes, putting the letters in date order, summarizing the problems so that consultations could begin with and build on this knowledge. It took Julian and Mary years to complete that task in evenings after a day's work. Later, the records were converted to A4 folders and bound together in family files. A system of color stickers highlighted particular conditions, high blood pressure, diabetes, smoking, and so on. Initially, the surgery was a wooden hut, but soon the practice moved to a newly built health centre, I think the first health centre in Wales. In 1966, he took full advantage of the new GP contract to employ the maximum number of ancillary staff, receptionists and nurses, the beginning of what would become a large team of practice colleagues, community health staff, researchers and doctors in training. These changes and improvements were the platform on which he could build. He was the first doctor in the world to measure the blood pressures of all his patients. The veteran study in the States had shown that treating moderate to severe high blood pressure could prevent strokes. Julian knew from studies in the Ronde d'Arc that high blood pressure often occurred without symptoms. The only way to find hypertensive patients was to measure blood pressure in everybody. And the first step was to screen the notes to see who needed a blood pressure measurement next time they visited, and to put a reminder in the notes. Practice nurses, Margaret Morgan's shown here, were trained to use a random zero signal manometer, state of the art then, obsolete now. The use of routine appointments to collect such measurements instead of separate screening arrangements or clinics, Julian called anticipatory care. Later on, the blood pressure data were entered on the forms at the bottom, sent to London for computer entry and returned as computer printouts. All that is much easier now. Eventually, one man, Charlie Dixon, was the last man to take part on condition that he was the last man, and he had the highest blood pressure in the village with a diastolic of 170. But after being put on treatment, he was still alive 25 years later. Julian became an international authority on blood pressure control in general practice and wrote a book about it, which went to 3 editions and was translated into several languages with a companion book for patients. A key step was measuring not only what he'd done, but what he hadn't done, what he called the measurement of omission. And in an article in the British Medical Journal introducing this idea, he wrote, back in the 1960s, before rubella immunization and the Abortion Act, a 6th unwanted pregnancy in a 42-year-old Glencorrig woman resulted in a child with severe brain damage. The mother had no apparent illness, but there'd been an epidemic of rubella in our village during the first weeks of her pregnancy. The whole family was affected. The father's smoking and alcohol problems went out of control into diabetes and coronary heart disease. As the child grew, he became unmanageable. With all ground floor windows smashed and replaced by cardboard, the home became a cave. In the insensitive jargon of health economists, he became a high consumer of services, first diagnostically, later for social and educational support. Now, as his exhausted relatives die or capitulate for the most costly service of all, full-time residential care. So when rubella immunization became possible, we wanted it to succeed. At that time, secondary school absence was running at 20% in 13-year-olds at the local comprehensive, and at least this proportion was therefore presumably not immunized. I wrote to a local medical officer asking for a list of girls missed so that we could get them immunized. I can give you the names of the ones we did, he wrote back, but how can I know the ones that we didn't? Well, the answer was to have an information system that included everybody, the denominator at risk rather than the numerator of activity. By measuring omission, Julian was able to address the rule of halves, the tendency in most systems for things not to be done or to be done poorly, and to increase the proportions of patients who were diagnosed, treated, and controlled. Julian hated when bad things happened to his patients, especially when they could have been prevented. In his last 28 years at Glencorrig, there wasn't a single death in women from cervical cancer, the result of well-organized and informed preventive care. Ascertainment and diagnosis were only the beginning. In his book, A New Kind of Doctor, he described a man invalided out of the steel industry after a leg fracture, aged 42. With no further use for his big muscular body, he'd become obese, had high blood pressure, high cholesterol, got gout, and was drinking too much. 25 years later, Julian described how after 310 consultations and 41 hours of work, initially face-to-face, eventually side-by-side, the most satisfying and exciting things had been the events that hadn't happened. No strokes, no heart attacks, no complications of diabetes. He described this as the real stuff of primary medical care. At the seminar in Glasgow, we asked Julian what happened next. The man had died of something else, a late onset cancer, I think. But when Julian told us of this, there was a tear in his eye. His patient had become his friend. After 25 years of working this way, involving 210,000 patient encounters, about 180 per week, he could show 30% lower premature mortality rates compared with a neighboring population. Possibly the only example in the world literature of what a general practitioner can achieve in a lifetime's practice. He did this partly by a population approach to the delivery of evidence-based medicine, for example, treating high blood pressure, but also, and crucially, by providing unconditional personalized continuity of care for all his patients. He showed that long-term commitment to a particular community could improve health, lengthen lives, and narrow health inequalities, even in the most deprived community in West Glamorgan. In his time, addressing the challenges of that time with the resources available, he not only imagined, but also realized the exceptional potential of general practice and primary care. He described audit as measuring what you do and being honest with the results. The most spectacular example being this review of 500 consecutive deaths in his practice over many years. It sounds a lot, but not over the period for which he was looking. And it showed that deaths were occurring at older ages because of prevention, and fewer deaths were due to smoking. Brecht's The Life of Galileo was Julian's favorite play, and he often quoted Brecht's line, "The figures compel us." Julian didn't pursue scientific knowledge for its own sake. He could never have been an ivory tower academic and knew himself well enough to turn down offers of university chairs. His research always had the direct purpose of helping to improve people's lives. Glencorrigh became the first general practice in the UK to receive research funding from the Medical Research Council. As an outstation of the MRC Epidemiology and Medical Care Unit at Northwick Park in Middlesex, the research team led by Mary delivered very high response rates for a series of studies on the prevalence of urinary incontinence, the role of bacteria in stool samples in predicting bowel cancer, and a trial of anticoagulant therapy in people at high risk of heart disease. I first visited Glencorrigh in 1975 as an Aberdeen medical student on my final year general practice attachment. Returning to the university bursting with enthusiasm, I was disconcerted to be cut off whenever I attempted to join the group discussion. As the professor said, he was glad that there was one Julian Tudor Hart, but only one. He didn't want his class contaminated by progressive ideas. In those days, Julian had been a communist standing for Parliament in 1964, 66, and 70, losing his deposit 3 times. And that alarmed many of his conservative contemporaries, quite a contrast to how he's revered now. The difference being that he speaks now from a lifetime of worked examples in his practice. Advocacy wasn't only what he said and wrote, it was also what he did. And reflecting on that transition many years later, he described re-entering the world as it actually was, rather than the fantasy world of our imaginations. The first rule of politics, Julian said, was to start where you are with the people you've got. I resolved to go back. Julian wasn't only imagining the future, but making it happen. Inclusive medical care, everyone on board, epidemiology, his map, science, his compass. Wherever my career I would go, I was certain it had to involve more time with Julian and Mary at Glencorrigh. So I joined what became later the unofficial University of Glencorrigh, one of about 20 GP registrars and MRC research fellows who spent time there, including Andy Haynes, John Robson, John Fry, Anne Delahunty. Brian Gibbons at the back was Julian's partner in the neighbouring village of Glangwimby. And the The presence of the MRC research fellows meant that Julian had a day every week, a Thursday, when he was free to do his writing, speaking, and other work. I was attracted first by Julian's writing. He'd a lucid, sometimes coruscating turn of phrase. When a Conservative Minister of Health, Keith Joseph, announced that the increased dental charges would give a financial incentive to patients to look after their teeth, Julian commented that while the government hadn't yet put a tax on coffins to reduce mortality, Sir Keith was assured of a place in the history of preventive medicine. The medical schools do not deliberately set out to impart smugness, careerism, and values unrelated to the needs of real patients in the real world. It comes quite naturally to them. It's true that the personal ambitions and professional satisfactions of doctors overlap with the needs of patients, but they don't coincide. Yet that's the assumption of a great part of medical education. So my slides are jumping to two, and I'm having to go one back. Intellectual opposition to social injustice, even when present, is only the beginning of understanding. If students are to retain patient-oriented rather than disease-oriented, they must learn to identify in complex, concrete, detailed terms with people they know only as crude stereotypes and of whom they're usually afraid. I found, as a young medical student, I found this stuff intoxicating. It was my good fortune, going back to work as an MRC research registrar, to be involved in the salt studies, exploring the ideas that high salt intake might increase blood pressure and that some people might be more susceptible than others. These were the first studies generated by the research team in Glencorrig and not directed by the MRC unit. We got funding from the British Heart Foundation, the first time it had given a grant for research in general practice. I remember they sent Professor Jerry Shaper down to check us out, just to make sure we weren't a bunch of cowboys. The first question we asked was, were people with a strong family history of high blood pressure salt hungry? And with Julian's blood pressure data, it was easy to identify adult offspring whose parents had either had both high or both low levels of blood pressure. We measured their salt intake, their sodium intake, using plastic jugs and containers to collect 24-hour urines. Not just once, but on 7 consecutive days, so that no one flushed their toilet for a week. There was no evidence that people with a family history were salt hungry, but everybody's intakes were high. So there was a second question. Might people with a family history of high blood pressure be more sensitive to the high levels of salt they consumed? And that required an experiment in which everyone reduced their salt intake to less than 3 grams a day. That's like living on a South Seas island, while taking part in a randomized controlled trial of salt tablets, bringing their intakes back up to usual, or placebo tablets, keeping it at the reduced level. But we borrowed this very elegant study design and the tablets from Professor Graham McGregor at Charing Cross, who had shown that salt restriction reduced blood pressure in patients with pressures high enough to need treatment. To pilot the procedures and using Julian's blood pressure data, we identified people with mildly elevated pressures, not high enough to need treatment, and in whom salt restriction might be a preventive measure. Here he is in a classroom in the local primary school, explaining the study to potential participants. The lines on these graphs show for each participant changes in sodium excretion on the left and blood pressure on the right, each dot representing 4 weeks of diet and measurements for one person. Salt intakes were reduced, not in everybody, but on the left, but blood pressures on the right hardly changed. The result was submitted to the British Medical Journal only 4 months after the study was first thought of, probably one of the fastest trials ever conducted, all because everything was already in place. The thinking, the information, the people, the relationships. It couldn't be done now. Not only would it take that long to get ethical permission would not be granted. The committee would say that patients were being coerced to take part by their doctor. But it wasn't like that. The doctor had an exceptional reputation for helping his patients. Patients knew that and were willing to help the doctor in research. It was an unspoken understanding, something an ethical committee might not understand. The negative results in people with mildly elevated pressures didn't exclude the possibility that some people might be more susceptible. But our subsequent larger trial in young adults with and without a family history of high blood pressure was also negative, reported at this international conference in Finland, published in the BMJ. The results made us skeptical of the SALT hypothesis. At best, it seemed a lot of effort for very little reward. But quite apart from the scientific question and the scientific answer, this was an extraordinary undertaking to take place in a free-living community. I know of nothing like it before or since. With Georgina Bingham, Maya Boast, and especially Evelyn Thomas, Pam Walton, Kath Edwards, and Mary Hart, we had an exceptional research team of local people. And they asked nothing of study participants that they hadn't already done themselves. A converted ambulance garage served as a laboratory and office. Low sodium bread was obtained from a local baker and delivered to study participants. But their most important task was asking, informing, supporting, persuading local people to eat very differently for a 10-week period, avoiding a large list of conventional foods up at the top, all the nose, and encouraging actually a rather limited list of things that they could eat at the bottom. This is a textile printed at Glasgow School of Art, 70 years after Julian's aunt had worked there. Now, common salt, as you know, is a chemical compound, sodium chloride, made up of a poisonous gas and a metal that explodes on contact with water. It would be dangerous with all that energy not locked away. In the same way that Cochrane's team had galvanized whole communities for medical research, regularly receiving response rates of 90 to 95%, 10 times the response achieved by UK Biobank, the SALT studies revealed the huge reserves of energy, goodwill, and cooperation waiting to be mined even in the most deprived communities, not underground, but on the surface of the Welsh coalfield. Perhaps the most important observation we made and the lesson I most remember. And from a personal point of view, the whole experience of working with Julian and Mary was a lifelong battery charge. To work and live with them at Glencorrig was to live life at a higher level. All of this, general clinical practice and general practice research, Julian communicated to the wider world in a series of over 150 research papers in major scientific journals, several of them classics of their time, and in books, in several of which the footnotes, references, and asides are worth reading on their own, reflecting his huge range of reading, contacts, and opinions. And advocacy via a host of articles and proposals, often swimming against the tide. He accepted speaking invitations from all over the world, notably Spain, Italy. Here he is sketching his Italian colleagues, Norway, North America, Australia. Julian could deliver formal lectures, but for brilliance and exhilarating an audience, he was at his best in impromptu, unscripted exchange. When principles were at stake, he could argue till the cows came home. In his younger years, he didn't take any prisoners. A famous medical professor reflected that he'd been called many things, but never a snail. Julian did mellow in later years, but he never lost his edge. Dr. Miriam Stoppard arrived in the village to interview Julian for her TV program, determined to cast him in the role of a doctor who made life or death decisions concerning his patients' access to renal dialysis and transplant. They battled for a whole afternoon. Stoppard trying to get Julian to say things on camera that fitted her script. He defied her, ending every sentence by mentioning how much dialysis and transplant surgery the cost of a single Trident missile could buy. She went away defeated and empty-handed. The world also came to him, hundreds visiting Julian and Mary at the Queen's in Glencorrig, as recorded in their visitors' book. Shown here are just 2 of 32 pages of visitors at all stages of their careers, some already eminent, many starting out, some worshipping, some skeptical, everybody learning. Standing for election to the Council of the Royal College of GPs, Julian topped the poll. What he offered GPs was a credible image of themselves as important members of the profession, alongside specialists, not beneath them. It was his experience that when a general practitioner knew his patients well, the problems they had to deal with and how they dealt with them, there were very few conversations on medical topics where he could not make a contribution. All that took place 30 years ago and more. The world has moved on. So what is his legacy? Well, not, I think in his view, the inverse care law described in an early paper, the 5th out of 150 to come, which he came to consider a banal observation, no more insightful or striking than the people who need shoes most are the people without shoes. Simply observing that the availability of good medical care tends to vary inversely with the need for it in the population served, especially when market forces are at play, has had little effect in changing the situation. 50 years later, the inverse care law continues. Market forces are being allowed in and encouraged, especially in England, generating social exclusion at both ends of the spectrum, the poor involuntarily, the rich voluntarily as they opt for private medicine. It's a poison in the system, adding to the long-standing mismatch of resources, a service responding to demands rather than needs, and the maldistribution of doctors based on where they want to work. All this continues to be documented in greater detail than Julian could ever muster, to no great effect. Despite numerous policy statements to the contrary, the inverse care law remains a de facto policy that restricts needs-based care. But Julian was unusual as a commentator on inequalities in health because, unlike most commentators who have little contact with policy or practice, he could do something about it. At a symposium in Glasgow to mark his 80th birthday, I summarized his work, showing that the combination of a population approach with long-term productive relationships between patients and professionals who know and trust each other and who are guided by evidence and audit is a powerful force not only for epidemiological research, but also for health improvement and a fairer, more convivial society. Important ingredients, important ingredients of his approach were inclusiveness, his whole population approach, the last person as important as the first. The importance of information using epidemiology to allow the measurement of omission. Straightforward family medicine, providing unconditional personalized continuity of care. Personal commitment, working in, with, and for a local community. Perseverance, staying long enough to make a difference. In a paper with Paul Dieppe in the Lancet on caring effects, Julian described the harmful effects when for whatever reason, health professionals become indifferent to what happens to the patient in front of them. I remember Julian talking of the importance of finding something to like about every patient. There was nobody about whom there wasn't something to like. Nobody was excluded. Julian was the worried doctor, anticipating patients' problems, not waiting for them to happen, and then avoiding them by joint endeavor. He began as a paternalistic, somewhat didactic doctor, but changed. He had to change. Initially face-to-face, gradually shifting to side by side. Julian was talking and writing about co-production with patients and the pace at which it could be achieved in a deprived community 20 years before it became a policy catchword. The Glencorrach practice was also one of the first in the UK to have a patient participation group in which the experience and views of patients could influence the running of the practice. His involvement in the local community went far beyond being a doctor. He campaigned for the setting up of the South Wales Miners Museum, was instrumental in setting up the Glencorrach Pond Cooperative, the beginning of the transformation of the village and its economy from an abandoned mining village to a centre for outdoor sports. Much of the pioneering work that Julian did is orthodox now. People have caught up with him. Much of it incorporated in the GP contract. Information technology in particular has transformed what is possible, opening up a new set of challenges. So Julian's legacy is not the example he worked out in the microcosm of a Welsh mining village over 30 years ago. It's the present challenge of how we follow and give practical expression to his values, working in local communities, making a difference in addressing current and future problems. In honouring his memory, there is work for everyone to do. At a conference in Glasgow in 2019, we celebrated three things: the life and work of Julian Tudor Hart, the publication of a book, The Exceptional Potential of General Practice, with 55 contributors from 11 countries, 44 of them GPs, the book dedicated to Julian and Mary. We also celebrated the work of 4 deep end projects. It was a conference which Julian would have enjoyed, with lots of young doctors imagining and working towards a better future. Many said it was the best conference in terms of company and content they had ever attended. One of Julian's cartoons gave rise to the deep end analogy, highlighting the problems and challenges facing patients and doctors at the bottom end of the healthcare slope, or deep end of a swimming pool. The cartoon gave rise to the deep end logo, including the deep end of a pool, the steep slope of need, the flat line of resource, a sunset or a sunrise, depending on your disposition. Top left, a thistle for Scotland, a spirtle or stirring instrument down the left-hand side. The whole thing, a flag for rallying under. The first Deep End conference in 2009, attended by GPs from 2/3 of the 100 most deprived communities in Scotland, was the first time this group of practitioners had ever been convened or consulted by anyone. The seating plan was a circle with everyone in the front row. The starting point was to listen and record their experience and views, which resulted in a long list of reports available in short and long forms on the Deep End website at Glasgow University, giving rise to the Deep End Manifesto, addressing the inverse care law, not as the difference between good and bad care, but as the difference between what practitioners can do for patients under current conditions and what they could do with more time, better support, and better connections. In Scotland, the Deep End project has had some successes based on worked examples and demonstration projects, the rollout to all Deep End practices of community link workers and embedded financial advisors. But we're still campaigning for more consultation time. A PhD student of mine, Rhiannon Babel from Oregon, interviewed a sample of GPs working in deprived areas of Glasgow. All saw their role in clinical consultations. Some saw no further than that, while others tuned in to patients' social situations, viewed the community as a resource, saw the social and political determinants of poor health being played out in front of them, and wanted to do something about it. The Deep End projects connect and support practitioners with this wider view. For an increasing group of Deep End practitioners, from newcomers to old hands, this is what they aspire to. It's the direction they want their careers to take. It's the collegiate culture they want to be part of. Here's the Scottish Deep End Steering Group. Meeting recently, lots of young GPs, mostly women. They are the future, the beating heart of the project, not waiting to be asked, not waiting for the future to happen, but imagining the future they want and making it happen. We don't have magic solutions, but we do have a direction of travel. In these difficult times, I see it more and more as a resistance movement. Following the example of the Scottish Deep End project, there are now 10 other Deep End projects in Ireland, Australia, Denmark, and 7 areas of England. They are local networks of GPs and practices with a wider vision of what they can achieve with shared activities spanning workforce, education, advocacy, and research. That's something Julian never had and which he very much welcomed. There have been 6 Deep End bulletins, each with 40 pages of shared experience and views, all available on our website. Julian has been their example and inspiration, and he left us with more to do, commenting in one of the early Deep End reports. Everything depends on leaders at practice level, demanding media attention, gaining public support, insisting on material resourcing from governments, in return for which they can guarantee immensely greater efficiency of care generated by people who know each other. He knew that to achieve change, new alliances would be needed with politicians and the public to put pressure on the establishment. Drawing on his reading of Marx, he saw healthcare as a form of production, producing not profits, but social value, sharing knowledge, confidence, the ability to live better with conditions, achieved not by the doctor alone, but by doctors, nurses, patients, and others working together. Patients as partners, not customers or consumers. The NHS should never be a business to make money, but a social institution based on mutuality and trust. The ultimate gift economy, giving what you can, getting what you need. A model for how society might run as a whole. In rebuilding society, cooperation would trump competition, not marginally, but as steam once surpassed horsepower. I think the Glencorrig research studies showed glimpses of that social power. In 1971, with the NHS barely 20 years old, Julian was concerned about the re-entry of the market into UK healthcare. As night follows day, this is a prescription for inequity and inequality. Asked how long the NHS would last, Aneurin Bevan replied, for as long as there are people prepared to fight for it, implying not one single effort, such as the battle over the 1948 NHS Act, but a sustained defence campaign like maintaining a Dutch dike, keeping the tides of market interest at bay. As NHS England steadily succumbs to market encroachment and privatisation by stealth, would-be defenders of the NHS are being tested as never before. Deep End practitioners argue that the NHS should be at its best where it's needed most. Otherwise, healthcare widens inequality, some groups benefiting more than others. Tackling the inverse care law needs cash, not words. Any other approach is building on sand. The main underexploited resource is social capital. How can that be harnessed? Can the Cochrane approach to high participation research be applied to integrated care? Who can lead such development? Working in a remote village in West Glamorgan in the 1960s, 70s, and 80s, it took an exceptional person to break and reset the mold of general practice. There are different challenges now for which we need not only pioneers, but also collegiality, sharing experience, evidence, and learning, and solidarity, pursuing the common interest. 2 weeks ago, in a Guardian article reflecting on her last clinical session in a career in general practice, the president of the RCGP, Claire Gerada, reflected that every patient had been a stranger. In 1973, writing for medical students, Julian wrote, "No one is a stranger." Julian saw the NHS not as the finished article, but as a work in progress, which we still have to imagine and realise. In many ways, we still have to catch up with him. His example and views have never been more topical or important. Thank you.
Thank you, Graham. Are you okay with having some questions?
Absolutely, yeah.
Great. Has anybody got any questions? Comments? There we are. I can see the screen now.
Yeah, it's a bit of a blast. I'm kind of assaulted my audience with stuff, but I was very keen to get stuff down on record, actually, and I'll be making an effort to make this not just the slides, but the talk available.
Thank you.
Can I ask a question, Carmen?
Yes, of course, Andrew.
On the list of the projects that you put up towards the end there, Wales was unaccountably missing. And
Yeah.
we had some sort of explanation last week about why that might have been, but how do you see the explanation for Wales's omission from the list of deep end projects?
Well, of course, that's not really for me to comment on. Jonathan Richards talked about this last week. I think there's an element of the prophet being ignored in his own land. There's an element of that. I think Julian was also quite threatening to local colleagues because he was implicitly saying, "Why can't you do this?" And people found that very unsettling. In some respects, it's been easier to receive his influence further afield. The key ingredient for the Deep End project is first of all engagement with frontline practitioners. If you haven't got that, then you can talk for as long as you like, but nothing's going to happen. You need other things like some sort of central coordination and continuity, but you have to engage with practitioners. And I don't think Wales has got past that first step. Some years ago, I had some involvement with a Welsh initiative which was supposed to address the in-birth care law, but it was really led by colleagues in public health. And when I'm in a combative mood, I like to point out that people with public health in the title often have very little contact with the public, whereas people who do have contact with the public in primary care tend not to think about public health. So when people talk about the marriage of primary care and public health, these two parties have hardly begun dating, never mind getting married. I think that's one of the reasons, but perhaps not the only reason.
Thank you, Graham. Oh, Christine?
Yes, thank you so much, Graham. That was amazing. Real eye-openers to all the work that Julian did. And it was excellent to see how he became quite a maverick with his background and his grandparents and all kinds of walks of life and attitudes to social situations. So he really was a man of his time and man of his family in that way. And it's lovely to see Mary with us. I'm so pleased to see Mary, that she's been with us today, and that there's no clever man without a clever woman behind him. And I'm sure, Mary, that you were behind him every inch of the way and every drop of the urine on the way as well. I know that must have been an amazing amount of work to do. So thank you. I'm also making my apologies for Lyndon. He's always got lots of questions and he's had to go off to another meeting now. So you're going to be excused from all his questions. But anyway, thank you, Graham. It was absolutely lovely.
Well, thank you.
Any other questions, comments? Can I ask one as the chair as such? How do you feel at this present moment? Just, it's very, very general, but how do you have optimism, any optimism for the future of sort of the NHS as we sort of know it at the moment?
Well, I'm very optimistic about young practitioners. and collegiality and working together. I'm not optimistic about institutions and the establishment. I think that many aspects of that are past their sell-by date and need to be reimagined. And when I said I thought the deep end had become a resistance movement, I think it has elements of that in the sense that it's connecting people who are not happy with the way things are and are pleased to be connected with like-minded colleagues in order to be working towards a better arrangement in the future. The present company don't need to be told by me what the concerns and issues are at the moment. But I think the message for young practitioners is that they have to belong to be, they have to be part of something bigger than themselves to make a difference. Julian was very important as an exceptional pioneer, and we couldn't be progressing without that example. But actually, you need a bigger army of people to be involved to produce change, and you need to have worked examples of what would make a difference, not just rhetorical, abstract, intellectual arguments. People can talk until the cows can come home, and words lose their meaning. Gosh, I'm just, there's whole areas I'm not just going to go into because they would be very topical, but you don't need me to tell them what they are. But I think the thing to be positive about is connectivity between like-minded people, somewhat against the status quo and working for a future in a progressive way. And the key thing is inclusion as opposed to exclusion. So many things at the moment are expressions of exclusion. And the important thing about Julian's example was that everybody was included. He found some to like, but everybody, even people who were hostile to him, he had to look after, and he found something to like about them. And that inclusivity, based on the assumption that everybody matters, is very much counterculture to some of the policies we have in the country, where some people are more important than others. And that's a message that goes well beyond our localities and countries. You know, it's a, you know, with the whole issue of migration for whatever reason, whether environmental or political or whatever, the inclusivity approach. I mean, the Ukraine thing is beginning to show that. That's you know, it takes big upheavals for, you know, societal urges to be expressed. You know.
Yes.
And in between times, the forces of darkness take over, and at the moment they have been in the ascendancy, and hopefully the house of cards is going to fall down, but who knows.
I'm with you there. Anybody else got any questions? Okay, then I'll hand you over to Andrew for the thanks.
Thank you very much, Carmen. When I was talking to Mary before this talk, she promised me that it would be a masterful talk, and so it's proved. Full of absolutely wonderful amount of information. You know, packed so much information into it, Graham, but also very, very inspiring. You gave us an account of Julian and his forebears. He was a product of an amazing combination of things. What a family, or families he had. I shall look up the Boston Ice King as soon as we're offline. A man with so many different talents as a GP, a writer, an artist, politician, polemicist, all kinds of things. And then, of course, on top of that, the social commitment, and perhaps more than social commitment, social persistence. And the persistence is really important, obviously. It's interesting that he obviously had a vision from very early age about what a doctor should do. But much more than that, he had a vision that he wanted to put into practice. And as you said, when he went to Glencorrach, there was the big opportunity. And I'm just amazed at what he succeeded in doing by combining the work of a GP with the work of a researcher in exactly the same setting. And you gave us some really good examples there. I was amazed to discover that his was the first practice to measure the blood pressure of all his patients, the first in the world. And then again, the SALT study, which you mentioned. All this is evidence-based, information-based medicine long before the phrase was even coined. And on top of that, of course, you mentioned the personal, which was very, very important to him. Teresa, who's with us today, I think you've mentioned several times now how very, very important it was that he knew his patients really, really well. And then you gave us the influence, the influence of Julian's work elsewhere. The University of Glencorrog certainly sounds something worth reviving. And then the Deep End projects on top of that in Scotland and elsewhere. The words that you've left me with that were associated with Julian are interesting ones. Of the three French Revolution slogans, liberty, equality, and fraternity, it's interesting, Graham, that you said that it was fraternity, which was the really critical one for Julian. And then you mentioned also solidarity and collegiality. Those are the things that really, really mattered. And I think everybody can understand that really well. So thank you. It's been a really wonderful hour. We're very, very grateful for the trouble you've taken in putting the talk together and the slides. And I think, Graham, you're going to be depositing both the script and the slides in the South Wales Miners Library, so they will be there for, well, not forever, but for a long time to come. Yeah. And just remind you, there is an exhibition on Julian in the Miners Library at the moment. If you can get to Hendra Island, it's there to be seen. So thank you, Graham, for a really stimulating and inspiring hour. Diolch yn fawr iawn. And thank you all of you for coming.
Well, thank you for the opportunity to put that story on record, because it's a very important story that needs to be remembered and celebrated.
Thank you. Can you please unmute for a second so that we can show our appreciation to Graham and he can actually hear us? Okay. Thank you, Graham. Thank you very much. And thank you also again, as Christine says, to Mary for attending today's lecture. So before you log out, can you please remember that the final lecture of in this excellent series is next Friday, not Thursday, it's Friday, the 11th of March at 1 p.m. When Professor George Davey-Smith discusses the inverse care law. And again, it was a reminder about the exhibition at the Miners. It's the Miners Library, isn't it? Yes. Okay. So thank you, everybody, yet again for joining us today. Thank you.